Hi everyone, I'm Dr. Vikram Jayaprakash.
I'm Dr. Russell Knudsen.
And welcome back to the Hair Loss Show. In today's episode, we're going to talk about hair transplant. And if you're experiencing an area of thinning on your scalp, how we manage hair transplant in those specific areas.
Welcome to the Hair Loss Show. Dr. Russell Knudsen and Dr. Vikram Jayaprakash discuss issues relating to hair loss and the medical and surgical treatment of hair loss in both men and women.
So we often find patients in consultation who come in very agitated because they've noticed hair thinning. And so my first question is, well, how long have you been aware of it? And they say, 6 to 12 months. I said, well, it's been there a lot longer than that because you have to lose a certain amount of volume in your hair before it becomes visible to your naked eye. The situation, they say, well, can we just fill the gaps in with a hair transplant?
Yes.
And that's where we have to use our judgment.
So I think in this particular case, we're talking about someone who's sort of presenting where they've got thinning of that area. Not that they've lost hair, it's not like there's an area that's devoid of hair. No. They've just sort of experienced thinning. They can see light shining through the hair.
They've lost just enough volume in the hair for it to become visible.
Yes.
And that will happen when you get to the 40 to 50% reduction in volume. You start to see.
And they go, Doc, listen, this is bothering me. Can we just transplant into the area? I've noticed it over the last few months, and I can't risk losing any more hair. I don't like the look. Let's just go book me in. When's your next available appointment? Let's do that.
So this is where we go back to understanding the principles of what we're trying to do. Hair loss is progressive, and this patient, they might have only noticed it for a short period of time, but it's been happening, and it's going to continue to happen. And so the explanation I give to patients is it's like leaking bucket syndrome. You're leaking hairs out of your bucket, and all surgery does is top the bucket up.
Yes.
So basically, if you don't want to try and stop further hair loss, then surgery is not going to give you that long-term permanent result you're looking for, because you're going to be back here in a couple of years' time. I started in the field when there were no medications. There was no minoxidil, no finasteride, nothing really for hair loss. And so the deal we made with the patient is you lose some, we give you some. You lose some more, we give you some more. You lose some more, we give you some more.
And the problem with that philosophy or that sort of game plan is that you're taking hair from back here essentially and moving it to another place where you don't have hair. That's a non-renewable source. So you've only got a finite number of hairs or follicles that you can use to keep filling a balding area. And the problem is that if you start and sort of redo a hairline as an example, then you've committed to that hairline. That's the sort of, you've got to defend that line come what may.
If you allow balding to occur, the worst that can happen is a natural pattern of balding. But once we operate, the likely outcome of further hair loss is an unnatural pattern of balding, which doesn't exist in nature, which forces the patient to continue down that operative path. And we are both very, very careful to emphasise that to every single patient. So yes, it can be too early to operate. Another reason why it can be too early to operate, apart from a patient not being on medication, is it going to make enough of a difference to make them happy?
Yes.
And that's again a judgment call. If it's not much thinning at all, but you've got a panicked patient, the risk-reward ratio is not necessarily going to be great and in your favour, because again, if we operate in an unprotected patient, meaning not on medication, and we put the hair in that they want, the disturbance of the blood supply as part of the operation in a small percentage of cases can cause a post-operative shed.
Yeah.
And they don't love it if you add hair and then they lose hair straight away because they feel like they've been damaged.
Yes.
And even if the hair is going to grow back, it's at least 3 months before they're going to see
the
any
shock loss that people
the shock loss that they talk about, and people are worried about it. And we used when we didn't have medications, we used to see it occasionally. I think there are people that are more sensitive to it than others. I think it probably happened more in the previous era of big grafts than it is in the current era of very, very tiny grafts, because we only make tiny slits in the scalp now.
Yes.
And I am conservative by nature about it. I don't want to overdo it. I talk to the patients about trying to get them to whatever the finish line is using the least number of grafts rather than the most number of grafts. And patients say, oh yeah, but I don't want to come back and do it again, so can't you just fill the whole of the upper scalp with hair? And I said, well, that might make sense to you. The problem for us is we don't know where you're going to go bald, when you're going to go bald, and if I use all of the hair on the back now, because as you said, and we re-emphasise, it's a one-time removal, they don't regrow, right? Patients who come in and say, oh, don't you just pluck them and they regrow? No, we cut them out and we move them. They do not regrow. So there's not only is there a finite amount of hair that we can move, but in most patients it's a reducing amount, because as the baldness progresses, if it's in the posterior part here, it's moving down into the area that you want to use as a donor area. So in fact, you've got less hair than when you started, just natural donor area. So it's a reducing asset, not a stable asset in that circumstance. So
and medication there is vital, because you're trying to preserve that. Not only are you trying to stop existing hair from falling out, or certainly the hairline moving back, but you're trying to preserve that asset as well, isn't it?
So what I try and do is, because often the patients come in and they've got a recession at the front and a little bit of thinning in this posterior vertex part here, and I say to them, well, let's do the meds. All right, because there's maybe a 35 to 50% chance we can thicken this up without operating, and we just do this because that's not going to regrow because there's the receded hairline. We'll just operate here and wait and see what happens at the back. And sometimes they'll go for that rather than want everything done at once. But the situation is that in early thinning, they are the patients that respond best to medication, ironically. And so they're asking for the wrong treatment.
I mean, it's interesting, isn't it? Because you talk about being conservative. I mean, you taught me, so therefore, by definition, I'm going to follow that same path. So you and I are absolutely on the same page. One of the things that I find difficult, and I'm interested to hear your talk on, is that because what you're suggesting makes absolute perfect sense, but what you're battling against is the background noise of everyone else selling, going, right, okay, no problem. I'll shave the head, I'll find the gaps, I'll put hair at the top as well. How do you go about, when you're talking to your patients, to sort of give them that information so that they can make an informed decision that actually, what seems to be great in the short term may hamper them in the long term and may cause greater problems for them, in terms of what the area looks like, the unnatural look of the area over the course of time, versus the depleting area, donor availability and donor surface area. How do you have that conversation?
So basically, the conversation is that we don't have a cure. We only manage the problem, and it's a progressive situation. The end line, the degree of progression, the amount of balding they had is unpredictable. Even in families with strong family histories of balding, it's unpredictable. My father was bald, my elder brother bald, I'm not, my younger brother not. Both my sons in their 30s, no balding. My wife's got 2 balding brothers. It's unpredictable. It's rolling the dice. Right? So we can't really give a great answer to patients, particularly the younger ones, as to what the final amount of hair loss is going to be. So I try and talk to them about it being an ongoing management issue between them and us. It's kind of like a contract. It's a deal we make with each other. And I tell people, unless you're willing to use medication for 12 months, if they've got no side effects, unless you're willing to use medication for 12 months, there's no point doing it, because you're not going to give it long enough for you to see what the outcome's going to be, right? Whereas there's only 3 outcomes. They're the same, which means they stabilised it. They're better, which means we improved it. The worse, which means we haven't got control of it, and we need to deal with that. And if we rush in and operate and they're getting worse, when I had no medications, sometimes the patients were losing faster than I could replace it.
Yes.
And they would come back every 18 months or 2 years for an operation, but they'd have lost more hair. They'd be worse than when they started. That's a very, very difficult psychological outcome for patients to accept. And so what I want is to build on something so that at least they're stable here, and then we build on it and they see the improvement, and that gives them that motivation to continue and not give up. So I think it's very important to spend the time.
Yes.
And yes, there are other clinics that will do this, where they just say, oh yes, you want, we do 3,000 grafts, we'll give you 3,000 grafts. Well, they're not interested in long-term management.
Yes.
They're interested in giving you 3,000 grafts. And that's when we run into the problem with the patient coming to see us 2 years later and saying, hey, I went and had this operation 3-4 years ago. They did 3,000 grafts. I had no other, I've been doing nothing since. And now look, there's grafts here, my hair's down here, I've got these gaps around the outside. What do I do now? And most of their grafted, most of their donor area has been used. So, we look for simple solutions, but it's a complex problem. There are no simple solutions. And, and young men in particular in our practice operate in panic mode. They want it
because this is really emotional, isn't it?
And they want the thing fixed yesterday.
Correct.
And they know that if they have the transplant, it's going to be they're going to see a result faster than medication will give them a result. And that's the problem that you have with it, explaining to them. And so, as I said, sometimes what I can do is I can sort of nurse them through it by saying, well, this area is only just starting to thin, so the medication will probably fix that and I can save grafts there. This I can't fix with medication, so we'll do this now. And then we'll come back and look in 12 months. What, and have to do a second operation? Well, it may be that you said, oh, could I have a bit more density here after you've seen it grown out? And then, nothing much is happening there. We can put a bit in there. So it's not a bad thing to come back at the 12 months and have a look at it and see whether we've achieved your goal.
And one of the things, and I know you say the same thing as well, is that I can never promise, you say to the patient, I can never promise you that this will be your one and only hair transplant procedure in your life. Right? No one can guarantee that.
So there's a reason we call this your first transplant.
Yes. But yeah, absolutely, right? And I think that's the thing, and unfortunately...
There's very few patients in either of our practices that you only ever do one operation on. It's a very small number of people. If you're committing to the idea of doing hair transplantation, you're committing to the idea of keeping things looking as natural and normal as possible for the rest of your life. And that is a long-term commitment, not a short-term commitment. And I promise my patients that if they will medicate and it's working, they will have less operations, spend less money in their lifetime than if they refuse to medicate. That refusing to medication as an informed decision is fine.
Yeah.
But I have warned them of the consequences. I have warned them that they will see me more often. Now with our patients, probably it's 5 to 10 years between procedures if they're medicating. It used to be 12, 18 months, 24 months when we had no medications.
This is a very, we can get very passionate, you and I can get very passionate about this topic, I know, because we feel very strongly about this. But just to recap on this particular topic, which is that, so if you are thinning in an area, it's really important to make sure that you're on medication to try and stabilize that thinning. And it may, negate the requirement for a hair transplant, full stop. But certainly give you the benefit of trying to stop this from getting any worse. And then now with the way we're performing the actual procedure, with the size of the punch being small enough, the size of the incision being small, slits being small enough that we can get between those gaps, that we can transplant into areas that are thinning quite successfully without causing excessive damage or too much damage to the existing hair. What about in areas where you get those individuals where there's just thinning of the hair? There's still adequate numbers of hairs, but they're just thinning. I think we'd be less inclined to operate in that individual and more inclined to say, right, let the medication have a good go in that, scenario.
I think that's very important. It's also important if you see patients that have any degree of miniaturization in the lower skull, that you really want to see what the effective medication is, because you've got to be a good candidate.
Yes.
To be a good candidate means you don't have a massive area of balding, that you have an adequate number of hairs in the donor area, and that those hairs in the donor area are quality enough hairs to give you a result that you're looking for.
Yeah.
So if you have very, very fine hair, for example, with low density in the donor area, we're not going to give you a massive head of hair. You're not going to look like Elvis at the end of a hair transplant because it's impossible. And an example would be, and this is public knowledge, is that in the early 1990s, Elton John had a hair transplant. But he's worn a hairpiece ever since, and no one's ever seen the hair transplant. And I spoke to his surgeon once. I met his surgeon at a conference, and I spoke to his surgeon. He said he had terrible donor hair, very fine, wispy, low-density donor hair. And so this just emphasises, again, that you have to be a good candidate if you expect a good result. And so, you know, these patients that have this diffuse thinning over a large area with you know, wispy hair, we really need to maximise the quality of those hairs, which is probably also going to maximise the quality of the donor hairs, to see whether it's going to give them enough of improvement to justify the intervention.
And it also comes back to the point that it's really important to make sure that you're assessed properly in person. Sometimes doing these sort of virtual consultations doesn't give you the opportunity to have someone examine your hair and be able to give you a full sort of a thorough assessment.
50% of my initial consultations are done by telehealth, and my philosophy is that I'm happy to do the first consultation by telehealth, but I can't assess them properly. I can't assess their donor hair. The videography is often with poor lighting, inadequate. And so what I say is this is part A or part one of a two-part consultation. The second one requires me to physically see you in person. Yeah. I make it part of the one process. And I say, if you want me to give you graph numbers, you know, particularly when, you know, they want a new hairline. If you're looking at them on a camera, you can't really demonstrate to them where the hairline could or would or should sit and what the graphs would to do it. So for people that you know, find it convenient to do videography and do telehealth, just remember the limitation for any kind of surgical analysis or estimate or planning really requires an in-person assessment. That's absolutely critical. And I would never, ever recommend to someone you meet the surgeon for the first time in the theatre. Right, that surgeon needs to have met you, have heard what you've got to say, and you have talked to each other, and you've had that communication so that you're both on the same page, because the outcome is critical to the communication process. Right, if you have poor communication, you can have unhappy patients. You can have a technical success but a cosmetic failure because you didn't meet the patient's expectations because you didn't understand the patient's expectations. And so it's really, really important to develop that relationship before you actually have the surgery.
Yeah. Cool. Well, that's a fascinating talk, and like I said, we're both passionate about that, so we could probably talk for days on that topic. But I hope you found that helpful and useful, and thanks again for watching. Please remember to like and subscribe to the channel, and we look forward to seeing you in the next episode.
I know Vikram and I are very gratified by the support you've given us over the last 3 years, so keep it up, people. We're really happy.
Thank you.